to join us as a Robert. See, I've said all those good things and now we're starting the recording. So let me start over. So it's my distinct pleasure and honor to introduce Dr. Manka Nkimbeng to you. Dr. Nkimbeng is an assistant professor in health policy and management in the School of Public Health. As I was saying, it's hard to believe, Manka, we've been working together for close to 5 years. She first joined us in the School of Public Health at the University of Minnesota as a Robert L. Kane postdoctoral fellow. After that, transitioning into a tenure track faculty role, again, in the School of Public Health at the University of Minnesota. Dr. Nkimbeng's work focuses primarily on developing culturally tailored as well as culturally adapting evidence-based interventions to improve the function as well as cognitive health of older adults from a number of different diverse communities, but principally and primarily the African immigrant community. Dr. Nkimbeng has really carved out a niche of national expertise in these areas. She won a Career Development Award a couple of years ago with a perfect priority score, I may add. She's also involved in a number of other different projects, those of which she is leading, as well as those that she is serving as key personnel and providing vital intellectual support. Again, it's just I just am thankful every day to have the opportunity to work with Dr. Nkimbeng, to see her work grow. I think many of you may know this, but if not, Dr. Nkimbeng was just recently named a Bush Fellow this past year. Again, just yet another indicator of the national expertise and profile that Dr. Nkimbeng has rapidly established in her academic career. So I'm going to turn it over to you, Dr. Nkimbeng, and thank you so much.
Thank you so much, Joe. Hi, everyone. I was saying before everyone got on the call that this is going to be a very different type of final presentation because the project has grown much, much bigger than I guess I was anticipating. So I will just present where we are and what we found, and looking forward to having a conversation with you all. I think there's a bunch of things that we can talk about as a collective group, and definitely things that will need your impact, your input on. Sorry, let me share my screen. Okay. All right, can you all see my screen?
Yes.
Okay,
yes,
perfect. So when we submitted our grant application, the proposal was called the African Immigrant Dementia Education Project. But like I was mentioning, it's grown and we're getting into uncharted paths, uncharted territories, and the impact is much bigger than we could think of. So there's a new name for the kind of the work that we're doing, and we're calling in our chatting paths African Made. You will know what African Made is as I go through the presentation. And so we're thinking about the impact of African Made with African immigrant communities across the United States. So I like to acknowledge the funding. Obviously, the very first core funding was from the RCMAR, which is why I'm here giving the final presentation. Also supporting me in the course of doing this work was my postdoctoral fellowship that Joe mentioned. And then also a little bit my K01 came in 2022, so it's been supporting me. And then also the North Star Geriatric Workforce Enhancement Program at the U of M to support some of my time in this work. So all of what I'm going to be talking about is made possible by all of these funders and these funding mechanisms. So this is not new to quite a few people here, so I'm just going to breeze through it. The racial and ethnic minority older population is growing. Studies on dementia care for this population are very limited. And then when we think about it, there's really a limited understanding of the burden of dementia in immigrant populations. Many of the studies that are out there can talk about racial and ethnic minority populations, but they typically do not identify if these are US-born persons or they are immigrants in the US. And then when we think about it, there's really a limited awareness about dementia within many immigrant communities, and in particular, the African immigrant community that has been working with, because the impetus for my RCMAR pilot was a needs and access assessment that we did with the African immigrant community that really highlighted from the get-go that there was a need for dementia education in the community, and then compounding on the need for or the limited understanding about dementia is also the significant challenges that persons face in accessing care and resources for various healthcare needs, including accessing dementia care and caregiving. And so then came in the African Immigrant Dementia Education Project. And our goal with that project was to develop culturally tailored dementia education program for the African immigrant community. We worked together with the Project Advisory Board, our community partner, African Career Education and Resources, Inc., ACER, and then we at the University of Minnesota, myself, Dr. Goglan, quite a few research assistants, coordinators, and volunteers to really get this work going and get work done. Our aims were really first to create an African Immigrant Health Professional Advisory Board to inform the cultural tailoring of the education program. Then we subsequently did, typically in the research world, we call them focus groups, but in the community, we call them community conversations and key informant interviews to inform the tailoring of the education curriculum and the materials. And then when we did that, we developed an African Immigrant Dementia Education Program and an accompanying book that we would then just pilot tested in the community. So to develop the education program, we had noticed that a lot of the cultural tailoring work that happens really happens without theoretical foundations and theoretical background. And so we decided to do it in a more systematic way. So we identified a model for cultural adaptation, which was the ecological validity model. And I've presented on this a little bit in my work in progress presentations. And then we also had a model for the process of cultural adaptation, which was the heuristic framework for cultural adaptation. And so these two models really guided the process of doing the work and also kind of the content and the cultural pieces or components that we really start to think about as we're adapting this work. And so this is an example of how we use the ecological validity model to really help us inform questions that we're going to ask during the community conversations and key informant interviews. And so you can see in the middle column is the meaning based on what the model proceeds. And then on the right-hand side are the questions that we really use to ask the community participants, be it the key informants or the persons that came to the conversations, to think through how do we really think of the cultural components of an education program as we kind of were developing it. And so we ended up having conversations with 10 key leaders in the communities. These were persons who were executive directors, church leaders, different kind of groups of leaders in the community. Some of them came to us through our project advisory board. Some of them came to us through my own community connections and kind of the leaders that I've been working with in the past projects. And so I have already presented this slide, but basically the majority female leaders that we talked to, the age was majority over the age of 40. And then many of them were first generation African immigrants and they were working full time. And then the other thing we find is that quite a few of them had some previous caregiving experience, be it professionally and also personally. And then the other thing I wanted to highlight is the religious background of many of these leaders. Those only one Muslim, but in the group that we work with. So when we're creating our project advisory board, we're more intentional to make sure that we got a Muslim perspective in there because we didn't get enough kind of information from the key leaders. And also when we're having community conversations, we made sure to target many groups so that we can get the religious perspectives in there. And so we had the 10 key informant interviews, and then we had conversations with 24 participants in the community. And to get to kind of the meat of the conversation, I'm not going to show findings from the community conversations, but I'll talk a little bit about some of the key themes that came from it. Again, we had that information transcribed and then analyzed it thematically. And these were some of the themes that came through that were necessary or highlighted to be included in the education program that we're developing. The very first key things that came out was trust and respect. Really, the community highlighting the need for us to be open, honest, and authentic in our conversations with them. Talk to us about asking questions, making sure that we're asking about persons' beliefs, behaviors, and listening attentively to make sure that we're actually capturing their perspectives. And then when we talked about when they talked about respect, they urged us in our education to think about when we're doing the education, following cultural channels, basically approaching cultural leaders, being polite and open in tone and expression and how we engage in the community, and then making sure that we're respectful of persons, avoiding the use of first names, because many persons in the community said that wasn't really a cultural thing to use first names. So they talked about addressing people by their title. If it was an imam, imam so-and-so. If it was a pastor, pastor so-and-so. So those little things. And then they went into other kinds of ways of showing respect. So thinking about, for some communities, signs of respect could be kneeling as a sign of respect to older adults. And in some communities, looking people in the eye was actually a sign of disrespect. And so thinking about all of those little nuances as we engage in the community during our education session. Then the other thing that came through was several Christian beliefs. So we talked about some Christians believe that praying will heal all conditions. Some people believe that healing, there's no healing that can happen outside of God or Allah. Then talking about the use of certain health products, such as the Jehovah's Witnesses avoiding the use of blood products, and the Catholics not using contraceptives. And then the goal was really telling us that we should be naming some of those things during the education session and having a conversation, an open conversation about it. We might not be able to eradicate all of these beliefs, but making sure that people were aware that these are beliefs that we knew were present in the community and having a discussion about it. And then when we talked about spiritual beliefs, some people talked about the idea that if people might believe that not talking about something and not maybe believing it just means that it doesn't exist. So they really highlighted the fact that as we offer education for dementia, it's really going to help break down or make people aware of what dementia is and basically the signs and symptoms and how it can be managed. Then they talked about cultural beliefs. The beliefs that were really highlighted were cultural beliefs around family care, family caregiving. And so the goal was to, in the education session, really think about how to provide education that would really talk about the nuanced perspectives about cultural beliefs that might not be able to hold in the US cultural context now for immigrants. And so really having participants at education sessions think about what it means for the things that they believe to not be able to happen in the US. And then the last thing that was highlighted was the stigma. We talked about different myths and stigma related to limited understanding of the condition, personal and family denial, fear of putting relatives in a nursing home, then thinking that dementia is normal. And the recommendation was really, we in the education program need to identify each of these myths and then debunk it with facts and figures. And so we took all of that information, developed a culturally tailored dementia education program, and we went through an iterative process with our project advisory board. So it was over 5 to 6 meetings of just going back and forth and bringing the content to the community advisory board to think through, is this okay? Is this good? Is this culturally appropriate? And so we went through that process, and then we subsequently developed our education program. And so what I'm going to show you is some slides from the education program, and then talk through how these slides encapsulate some of the content that was recommended from the community conversations. So these are 2 slides from conversations, education sessions that were happening in the community. The picture on the left-hand side, my left, is the research coordinator at an education session that was happening with Muslims. And then to the right is an education session that was happening at a local city library, and I was the person giving that presentation. So we ended up, it was important that the education had a title, and so the education program now is titled African Made, which is African Memory and Dementia Education by and for the African Immigrant Community. It's very important by all involved that we talk about the process of it being co-created and not developed by the youth team. So you can see that immediately under the education program, it's written that it's co-created by the Immigrant Memory Collaborative, our community partners, and the project advisory board. And so those were things that were very important for the community and the community partner to recognize everyone that was involved in the development of the education. And then we're recommended to kind of talk about what was already happening in the African immigrant community and providing some of the facts related to the condition for the community, because that was important to know. So the education begins with us talking a little bit about what the results of needs assessment. So we highlight the fact that the needs assessment was done as a collaboration, we also highlight the fact that many persons in the community agreed from that needs assessment that there were many cultural issues that were influencing persons from getting care for a relative who was living with memory loss and dementia. Then the other thing we highlight was the dementia knowledge assessment that we did in that needs and access assessment. So the needs and access assessment was surveys with about 193 participants, and we administered a 25-item dementia knowledge scale. And out of those, the mean score in the sample was 14/25. So it really highlighted the fact that there was a need for dementia education in the community. And oftentimes when we tell people these findings, they all agree. And it was one of those things that as soon as we said it, everybody was in agreement and their ears were perked to now then kind of listen to the dementia education, because it was something that we highlighted in the data that there's a need in the community. And then you remember when the participants wanted us to ask questions. So each of the sessions of the education starts with a question. And so we would ask the question, ask for audience feedback, and participants would talk about what they thought were the responses, and then we'll dive into the conversation about kind of our presentation. And the participants really liked this as really a way of opening the conversation for them to be part of the conversation during the education. So we presented a slide about the current burden of dementia, talking about some of the facts that are currently available, and then we really would dwell or highlight the facts that are pertinent to the community, like what is happening for racial and ethnic minorities, about the burden being higher, them being diagnosed at later stages, them having a fewer number of diagnoses, and also the increase in medical care that is often seen for racial and ethnic minorities with dementia. And then you remember they talked to us about really identifying what the myths and beliefs are in the community and then really debunking them. So this slide, although it's just one slide, will take close to 10 minutes because we'll be talking about each of these myths that we found in our work with the community and then carefully debunking it as a community during an education session. So these were some of the myths that we found that are prevalent in the African immigrant community related to dementia. And so we'll talk about each of this and debunk it. And then following that, we typically would present really a picture of what is happening in the brain with dementia. And we show these images to really help people understand why they're seeing the different types of signs and symptoms that they'll see in dementia, and really talking about how different dementias look different for different people, even if they have the same type of dementia. So we'll have a good conversation about this. And this is one part that often takes we often get a lot of questions from the participants asking about more intricate questions about the brain and little things that they have seen in the community. So this slide typically brings up a lot of conversation. And then we'll get into the 10 warning signs, talk about how the 10 warning signs present, really being able to help them decipher what is normal aging versus what is a warning sign for dementia. And then we'll get into the risk factors, talking about, advancing age, and there's really nothing we can do about that, or the family history or genetic risk, but then spending a lot of time to talk about kind of the modifiable risk factors. And a lot of people have heard about heart-related risk factors, and so we often try to tie the dementia, cardiovascular disease, brain health connection. And so for a lot of people, it makes sense to just talk about whatever you're doing for your heart is also good for your brain. People typically resonate with that message. And then from there, we'll dive into talking about how to prevent dementia and really thinking about keeping your mind fit. So we'll talk a little bit about this and get into the different components of this image, talking about how many numbers of hours of sleep people would need a night, what types of exercises people can do at different physical activity levels, and really how to build up based on each of these ways of improving brain health. And then we'll get into talking a little bit about the diagnosis process and really thinking about from not having symptoms to having symptoms, what can be done and what is important. And one of the things that was highlighted in the during the community conversations was really talking about the barriers that can influence Africans from accessing care. So we typically talk about the barriers that Africans would face. And in addition to talking about some of these barriers, like the experiences with healthcare in Africa, African attitudes towards preventative care, for many persons, before coming to the US, they had never gone to see the doctor unless they were sick. So we'll talk about some of those things that are traditional things that people would normally do and not know. And then we'll highlight the need for making sure that people had a primary care provider, making sure that they read up about whatever medical conditions they have. And in addition to this, we always brought with us resources from the Alzheimer's Association, the senior groups in Minnesota. And in addition to that, we would actually, whenever we're hosting dementia education sessions, we would invite some of those partners to actually come with us to those events. And so there will be tabling at our dementia education events. And so that was a way of bringing in resources into the community when we're giving the dementia education as well. And then when we talked about accessing care, we really just helped people understand what was the management, or what is the management like for a person living with dementia. So we'll talk about some of those components and really help persons think about how dementia is not a one-man show, or dementia care is not a one-man show. It really involves the community and involves a wraparound services for the persons. And oftentimes we'll get questions from current caregivers about where they can access some of these resources that we're talking. And so it's a great opportunity again for us to link them to care, provide resources for them to access different types of services, because they might not, many of them do not even know that these resources might be available to them. And so this slide also often brings up a lot of conversation. And then when we talked about that, we now went into talking a little bit about family caregiving, because a lot of participants talked about the expectations. And so this was another slide that we'll present and talk a little bit about the cultural expectations that Africans have. So these are some of the ones we'd heard in the community. You know, our parents took care of us, so it's our responsibility to care for them now. Or depending on what cultural context you come from, it's the daughter that has the responsibility, the last born son. And so we have this conversation in a nuanced way to think through, what if you are the person who has the expectation to provide support for a relative with dementia, and you actually physically cannot do it? Maybe the person living with dementia is here, and that family member is not in the US, or they're in a different state, or they're not in a financial circumstance to be able to provide that care and support. And so it's really thinking about what are the different family or cultural context expectations that the community has, and how do we begin to balance those in supporting someone living with dementia in a community and context that is very different from where the cultural expectations came from. And then with that, we'll also dive into talking about the caregiver and really thinking about how the caregiver is a critical component, or the caregiver and the care partner, they are critical components in supporting a person living with dementia, but oftentimes they get stressed and burned out. And so we'll definitely dive into the signs and symptoms of stress and burnout. And our goal, again, is not only identifying what is problematic, but really helping the attendees think about how to improve their own health, if they're caregivers, or if there's no people who are caregivers and care partners, how to support them in improving their own health. Because I think I recently heard of a statistics that for supporting someone with dementia, there are some statistics about the care partners often dying before the person with dementia. So we really talk about that, the importance of care partners taking care of themselves. And so we typically end with them talking about how care partners can prevent stress and burnout. So we talk about the typical things, exercise, managing their own health. We'll also highlight the last 2 points, which was making legal and financial plans, making sure that the care person living with dementia, as soon as they have a diagnosis, is aware, can put their kind of make arrangements for whatever needs to make their legal plans, make their financial plans, and make sure that the whole family is aware of these things. And then also highlighting, because we found, especially after the first several conversations, that for many African immigrants who migrate to the United States for greener pastures, there's this belief that hard work is what is critical. And so we have care partners and caregivers who are not necessarily seeking for support, either from family or from the community. So we really reiterate the fact that dementia caregiving is a community process, and it takes more than one person. So encouraging participants to seek for support. And then we also provide them some resources as part of the education program. And then, so we started our pilot session for the dementia education in September 2022. We ended in May 2023, and we were able to have about 187 attendees in person. One of those sessions was live streamed, and stored somewhere on Facebook. And the last time I checked, which I think was 4 or 5 months ago, had over 1,000 views. And then we're also doing pre and post data collection for the dementia education. We had about 81 persons that were able to complete the data at the beginning of the session, and then also at the ending, but there was a bunch of people who came late. So we had about 28 partial surveys that were collected. But as you find in my analysis, we only really end up having data for 77 participants for pre and post. So these are the questions, the demographic questions that we would ask. Again, our project advisory board was very, very adamant that we could not make our surveys longer than a sheet of paper. And they told us that if we made it longer than a sheet of paper, participants were not going to complete it. And still, with this one sheet of paper, there were some participants that did not have the time to complete the survey. So we basically just asked the most limited information about the demographics and really wanted to understand how caregiving was influencing dementia knowledge. So we asked about current. Number 8 is past caregiving. Number 9 is current caregiving. And then number 10 is, have they provided care in a professional capacity? And that's a flyer for one of our dementia education sessions with the Muslim community. And then these are the 10 dementia knowledge questions that I would ask. And so we'll ask 10 questions related to some of the content that we've offered. So we ask about the burden of dementia, we ask about the definition, we ask about the most common forms, we ask about risk factors, caregiving, and some of those things that we've offered in the education session. And that's a picture of me actually at a Muslim community organization. You can see that I have a scarf around my head because, again, it was critical in that all women who enter the masjid have to have their hair covered. So when we're going in to do the dementia education, we took off our shoes, everybody, all the women were, and also putting on headscarves. That's me helping one of their leaders complete our pre-survey. And so then the other interesting thing that happened was that for several of this dementia education, the dementia education that we did was live interpretation. So that's a picture of me doing it with a Somali group in Wisconsin, where we had an interpreter doing it live with me. We are yet to go and really analyze and see if there's any difference in the knowledge gain based on if it was live interpreted or not. There was 2 that we had live interpretation for, and then there was 1 that was actually done in Pidgin English, because I also speak Pidgin English, and I did it with a community of West African older adults in Pidgin English. So we'll also be curious to see how the language of presentation impacts the knowledge. So 77 participants in total were the people we got data from pre and post. 55 of them were first generation and 12 of them were second generation. So first generation, born in Africa, migrated to the United States. Second generation, born in the United States to parents who were born in Africa. So the age ranges really were spread. There was no big deal. There were majority female persons that were attending our education session. And then the education levels were pretty high, but there was a decent number of people we found who had less than high school education. Then we found out that not as many as we anticipated were offering current caregiving. So it was only about 9 persons that were current caregivers, and then about 20 were past caregivers. And then when we looked at those who had some professional experience in care, providing care for a person with dementia, was only 17 of those that had some professional experience. We actually had thought that would be more because of what we found in our needs and access assessment, but that's something that we'll think about. And it could just be that people who were coming to the education were people who actually needed the knowledge. And so a lot of the caregivers, persons who have provided care in their current professional role, already thought they had the knowledge and so did not come. All right, so we were curious about a couple of things to see if education level would impact the change in knowledge. And you can see that there's really no difference across the educational level. Regardless of whatever education level you had, there's really nothing that can be said. It was a little bit wonky both ways for the people who were less than high school education, and then even for people who had a graduate degree and above. But when we looked at people who had some professional knowledge and caregiving, we could see that things were trending in a different direction, where people who had some professional experience of caregiving were typically coming to the education with a little bit of higher knowledge than people who did not have professional caregiving. That was something that we expected. And even though the numbers was only 16 persons, it was showing that that's kind of true for what might be happening in the community. And I think that makes sense. And then when we looked at really what was happening before and after, we could see that the beginning score was 6.8 over 10 for the pre, and then after it only went up by 1 point, but it was showing that there's actually change in knowledge that is happening with the dementia education. And the change in knowledge is very slight, and people were coming in with very high knowledge already about dementia. And so we have to think through our questions and really thinking about, are we asking just the basic questions, or do we need to start thinking about asking more in-depth questions from the education that we're providing? But this is encouraging to show that there's a change in knowledge from before to after participants attended our education session. And then this was really also highlighted by quotes from the participants at the different education sessions that we've had. A lot of them highlighted it, some of the things that we were attempting to do, saying that it was very interactive, and then also highlighting the fact that we're using simple terms and language to explain it. A lot of them talked about how they were taking this dementia education and sharing with their families. And typically, most of them actually are not only sharing with family members in the US, but they're also sharing with family members back home in their country of origin. Then we've heard this many times, a lot of participants talking about how there's a need for really more education in the community, and saying that we should probably be doing this more often. And then the last thing was our goal of presenting resources to the community. There's a quote about it was an amazing and very resourceful presentation. So participants really enjoyed and welcome the information and welcome the resources that we were bringing with us at the education sessions. The next thing we did was developing the dementia booklet. And so we worked to develop the dementia booklet. And when we developed the dementia booklet, we wanted to just let the education, put it in the community and start kind of dividing or disseminating. But our community partners and project advisory board was like, no, you cannot just have a book and then you don't launch it. So we had a dementia booklet launch event, which was June 1st, 2023. And this was our team. You can see Joe there and the rest of our team. Everybody was very happy. We had an MC, it was a big launch party where people came together, very excited about this book. And we got a lot of feedback and comments about the book. And many people in the community loved the book, loved the education, loved the content, and loved the work. And now you can see that the work is actually gaining a lot of traction and a lot of momentum in the community. We were recently featured in 2 local newspapers about the book that we developed. So that's a picture of me and the executive director of our community partner organization talking about the book and kind of our plans for next steps in disseminating the book. And then one of the reasons why we're kind of where we are with work is that there's been a lot of work in thinking about how to disseminate the dementia education. And so we've been hard at work, really trying to think about funding for next steps. And so currently, my KO1 is still funding me, and these dementia education sessions have actually proven to be a good kind of recruitment approach for my KO1, because at the end of a dementia education session, I typically talk about my KO1, which is recruiting dementia care partners to talk about their experiences. So that's been a nice way of providing the education and then also recruiting participants for my KO1 project. And then we're recently funded, I think this month, as part of the renewal for the GWEP, to have funding for 5 more years of disseminating this dementia education program and the booklet. And then we also have an application under review with the Alzheimer's Association for another grant to kind of help us disseminate this work. And while we at the UL have been actively looking for funding, our community partner has been doing the same. And we got note from the Minnesota Board of Aging that the community partner was also funded to disseminate this dementia education. And I think they're going to be signing the contracts at the end of this year, and we'll be getting that grant funds to disseminate this. And then because of this media story and all of the media pickup that is happening, we've been getting a lot of calls as to, can we buy the book? Can we donate funding for the book? So we're now having to do a lot of meetings to think through, is there a donor or is there a book purchase avenue that we can do to fund the dissemination of this education program? And then we've also been in a lot of meetings with the Alzheimer's Association with the Minnesota Department of Health, thinking about how can they sponsor this book, how can they support the dissemination of this book, because this work is really aligned with their own vision for dissemination of dementia education in the community, especially because we're doing it in a culturally appropriate way. So there's a lot of work in the funding space right now, and there's a lot of meetings happening to think through how do we disseminate. And for the research team, we're really now thinking with some of this funding, thinking about hiring the staff, thinking about developing a comprehensive training protocol for the dissemination of the book that really incorporates some of the cultural things that we're incorporating into it. So it's the process of from the getting a call to come offer the dementia education to after the dementia education, there's a lot of cultural pieces that are part of the process. And so we need to make sure that we document that and are able to teach trainers so that when they are doing the education, they are also doing it in a culturally responsive way. And so we're also developing a train the trainer protocol, a model, so that we can have that, developing the logistics of once we get a call from community partners, what needs to happen before the education session is planned and is organized. And sadly speaking, most of that has been by me, myself, and my coordinator, but my coordinator actually left this week to go to residency. And so it's just me being one of the members of the team now. So we're in the process of hiring some more staff to really think about all of these processes that are needed to be able to disseminate education in a culturally responsive way. And then I just want to thank everyone who was involved in the project. Again, our project advisory board members, the key informants, the community conversation participants, again, the many community partners that we've partnered with, and then also the participants at the dementia education. So that's a picture of myself, my mom to the far right, who's been a great support system because she goes with me everywhere, administering, helping coordinate crowd, helping bring people into the room and all of those things. So she's an informal member of my team. So just wanting to thank my village and thanking you all for listening to me. And I'm looking forward to the conversation that we're going to have about this and some of the things that I've discussed. Thank you.
Manka, wow, just simply wow. Congratulations on all this work. I just want to take a moment to say that I remember when you were a doctoral student and I was on your committee years and years ago. I have to honestly say I've seen you grow as a scientist, and this is just a small inkling of what your career is going to look like. I'm very proud of you. I'll open it up for any questions you have. And also another thing I want to say before I open it up is I want to say to Joe Gogler, thank you for the support that you provided to Manka. It's been very instrumental, and I can see the hard work paying off. So I really want to say thank you for doing that, Joe. And you and I have been working together with a number of people around the country. You've been very supportive. So I really want to acknowledge that and thank you.
Oh, of course. With Manka, Manka makes it a pleasure. So thank you, Manka. Great presentation too.
Yep. Now we'll open it up for Joe Gallo. Let me. Yeah, you have your hand up. Yeah.
That was terrific. That's really fantastic what you're doing. I had two comments or a question. One was if it's a 10 item for the knowledge and you got that 1 point improvement. I was like, I guess what I'd wonder is just look item by item. Like, is there 1 or 2 items that everybody's getting wrong, or, maybe that could guide how you evaluate their knowledge. Like, I guess they're coming into it with a higher level of knowledge than you thought.
Yeah, thank you. We began doing that work. It just wasn't complete for this presentation, but
sure.
we began.
Yeah.
Thank you. We'll be looking at it. And the other thing I did was looked at the internal consistency, and it was a wonky number. So pre was 0.69 and post was 0.8. So I was like, it's the exact same questions and the exact same population. Why are we getting to different alphas? But we're definitely, thank you. We're definitely going to look at each item and see how it's performing.
The other thing I was wondering was, I guess there are two sort of things. I guess there's really a question, sort of, is like, it's not just the content, but who's the messenger? Like, and I'm wondering what your thinking is on the messenger, and maybe it's related because I guess I have certain reaction, or I wonder when you say, like, somebody has, you're addressing those cultural beliefs people have. It's good to get that in the open.
Mhm.
But I wonder, knowing just how people are, what does it mean to debunk them? Like, yeah, sure, I could provide facts, and then when people go home, their neighbors are still saying the things on your slide. So anyway, just wondering how you thinking about that.
No, you bring up two important points. I think the very first one is that there's a way of identifying myths and debunking them that is culturally humble, and there's a way of doing it that is not culturally humble. So
Yeah.
we've been thinking a lot about, we asked the participants to tell us who would be the ideal kind of person to offer this kind of dementia education. So we have that information, and then we've been thinking in our protocols, really trying to create some sort of, I don't want to necessarily call them scripts, because it's not going to be from people reading from a script,
Right.
but kind of advise as to how do you bring up certain topics. And that's a conversation that we're doing with the community partner, and we're doing with the advisory board. So getting everyone's input on how to bring up some of these things, because from the way we've been bringing up, it's the way we've discussed it in our project advisory board meetings. And so it's making sure that we document that process in a protocol so that people are able to emulate it for future sessions.
Yeah. I don't want, one more thing. It just occurred to me, like, this in a community setting, but I wonder if you take the same kind of thing and make it, let's say, specific to somebody who's going to have a doctor visit, let's say, and then it becomes part of the, how do you interact with the doctor or the health system? I don't know. Not obviously not a well thought out comment, but I'm just saying, there may be other venues where really, when the rubber's hitting the road and people are really, are dealing with it, or dealing with the doctor and won't listen or something like that. But it's great. Really, really great.
Yeah. Yes, George.
Yeah, Manka, that was just terrific, and it's such important work. And it sounds like this is just really taking off. And you just did a fantastic job summarizing the work. I was wondering, I really like the notion of community conversations, and it just seems to resonate very well. And I was wondering, is it different than doing a focus group? I mean, is having a community conversation, is there something different? Was the methodology the same in collecting the data as a focus group? Did you structure it that way? Or is there something sort of added in the community conversation that may not be present in the focus group? Or are they interchangeable? It's just a way of sort of branding it so it's more acceptable in the community?
For our team, yes, it's been, we can say focus groups are interchangeable, because we created a guide and we go in and we have the conversations happen, and then for all of them, because we needed to, we had them recorded. And so in some ways they were very similar to focus groups. But when you talk to the kind of the persons who are community advocates and talking about a community conversation, most of them are typically talking about it not having guided questions, or maybe just one question that leads the conversation, and then people just have a conversation. And oftentimes a lot of people talk about it not being recorded and just having notes taken. So it really depends on what viewpoint you're coming from. Yeah.
Thank you.
Gail?
Hi, Manka. I just want to say, first of all, it's an honor to know you, as I've learned from you and been inspired by you. And this is all because of JHAD-RCMAR, because of Dr. Reebok and Thorpe and Dr. Joe, creating this wonderful space for us to just grow as people. So thanks, everyone. A quick response. Have you thought about introducing, I'm sure you've integrated this, the positive protective benefits of aging? Well, because I was talking to someone about that, and she was saying, when you put it in that context, I probably will consider, you know, exercising or doing something to conserve my cognition or my cognitive reserve. So I'm wondering, has your audience been responsive to that? And my apologies for being 10 minutes late. You probably already introduced this. Thank you.
Thank you. In our work and in the way we've done it, we typically take a strengths-based approach. So even when we're presenting the things about how you can improve your brain health, it's all taken into, if you're already doing something, this is how you can improve it. And then I think that's the approach that we take. Is that what you're asking?
Yes, exactly. The strengths-based approach. Great. I wanted to hear about your experience because it just dawned on me that that may actually win more people over. I don't know if we have 30 seconds, but a lady was mentioning to me, because sometimes I resent going to the YMCA to exercise. And this lady came out of the gym and she saw me looking like I didn't want to go in. And she says, do you know I have to get dialysis several times a week? She says, just consider this your dialysis workout. And I never thought about it like that. So now when I go to the gym, I said, well, maybe this will prevent me, you know, from having to go and have dialysis. So it's the positive trade-offs, I guess. So the strengths-based perspective is exactly what I had in mind. Thank you.
Can I ask a question?
Yes, please.
Sure.
Thank you. It's been so good getting to know you and learn from you and to see what I can do someday myself, Manka. So this is super cool. So as you might recall, I come from education and now I'm in public health. And so it's been interesting to observe how we approach pedagogy in like educational spaces and that an academic field and study it, and how we do it here in public health. It seems that community culturally like, responsive pedagogy in education, they're more open to teachers not of the same background or race or gender and so on, just so long as you follow what they term culturally responsive or sustaining pedagogy. It seems like in public health, I've learned that's not the case. In your experience and like your research, and I don't know, like, and so I'm asking you, like, what do you think the two approaches of education field and public health field? What's the difference? Why do you think the two might be seeing things a bit different? Like, what about public health education is different, say, than teaching math or English or social science in schools? Does that make sense? Like, it's a vague working question. I apologize. I'm just curious your thoughts.
So I would answer broadly and help talk a little bit about what I think, at least from the perspective of our dementia education. I think what we typically find in education system is that some of the concepts that are being taught are hard and fast. 2 + 2 is 3. But when it comes to public health, with teaching and educating on things that are more complex and related to behavior, and behavior is deeply culturally ingrained. So if you think about what culture is the belief systems, the values that we bring to things. And if you're teaching about diet is deeply ingrained in culture, it's deeply ingrained in belief system, it's deeply ingrained in cultural practice. So as a public health practitioner or public health nutritionist teaching someone about diet, you have to take a couple of steps back to think about what cultural group are they coming from. If it's about diabetes and diet, are they coming from a group that primarily eats carbohydrates? Because that's critical to tell them to eliminate carbohydrates. Carbohydrates makes no cultural sense for that community. You're literally not valuing their culture. So I think that's where the public health perspective, the concepts that are they're engaging in, is, to me, appear to be very different from what the educational side is engaging in. With that said, I think we can still do education in culturally humble ways that still value different ways of learning, still value different ways of knowing, because that's the other piece that people know, even if they don't have a certain level of education. A certificate does not necessarily mean that you know versus you don't know. So I say all of that to say culture, even though it might not be playing a role in kind of traditional education, I think it should, because culture is critical in the way we learn and the way we live. And so culture is critical. But when it comes to our dementia education, those are some of the things that we really were asking participants as to who do you think it's critical in being the person to offer this education. So we asked about the race of the person, we asked about the gender or the sex of the person, we asked about kind of a little bit about the background, professional background of the person. And I think one of the things was they felt someone who understands the culture, it might be learned or it might be innate, could be a great person to do the education. And also really thinking about someone with some sort of medical background would be great, because while we're offering, we call this dementia education a comprehensive introduction into dementia, questions can often come up that are more in-depth. And so it will be ideal for someone who has some background to be able to talk through some of the more complex pieces of the education. But that's kind of my opinion on that question. I don't know if you want to talk more about it.
Thank you. That is a lot to digest. I appreciate that. Again, thank you for teaching. I appreciate it, Manka. Congratulations.
Thanks.
Netta?
Hey, Manka, excellent presentation. I do similar work, but with the faith community. And you kind of just spoke to what I was going to ask you about. I found that in doing these workshops, and I take a train-to-trainer approach with health ministries and the nursing ministries, different names for different churches. But what I found is when they're in the group, sometimes the questions come up about medications, the most recent medications. I actually had a Johns Hopkins nurse to go over signs and symptoms, but we didn't talk about medications so much. And I was just wondering, have you experienced that and how you handled it? It just so happened one of the last workshops I did, it was a physician actually there, and he started talking about recent medications. That has come up. And the other question I have real quickly that to speak to is I found that although you give the knowledge and you tell them preventative measures, I love the fact that you actually had the brain images so that they can see exactly what's happening. We are still working with people in the community that have limited access to certain healthier foods. And then there are others who are on medications for chronic diseases, and they're not going to stop eating the foods that they have access to or change their diets. Have you approached that? I heard you mention the carbohydrates, in the culture, in this culture, you're not going to say, well, stay away from carbohydrates. Other suggestions for them, or did you get feedback in reference to that? Thank you.
No, thank you for your questions. I will take the medication questions first. So I think the way our team has been lucky is that the two people who typically go out is myself, who's a nurse, a clinician. So I know I'm a nurse by training, and so I know medications, and I often talk about it, and I'm up to date on the dementia medications that are kind of coming out. And so we do have a conversation about that. And that's a point of, we have to think about how to tackle it in our protocol for persons who might not be clinically trained. And my research coordinator was a physician who had not started residency. She just started residency this week. So we had experts there. So that is definitely something that is important. And medications often come up. And so especially the numerous multivitamins that have been put forward as medications that can prevent or cure dementia. So there's a lot of debunking of some of that too that is happening at these education sessions. So medications do come up. And then in terms of the diet, we do a lot of education around diet, and there's some sessions that I've done. The good thing about this kind of work is that it's branching off. So there's a community partner in Maryland that has funding from the Maryland Department of Health to do dementia education in Maryland. with that community partner, they are bringing in different experts. And the last education session we did, we brought in a dietitian to exactly talk about kind of some of those things that are happening. And what we've done is that we're bringing in resources from the Alzheimer's Association here. And we're also thinking about who else is doing culturally relevant nutrition work that we can begin to invite to come to some of these education sessions. Because yes, we cannot just talk about all of this thing in an abstract sense and not really make it culturally relevant, because it's not going to be implemented after the leave our sessions. Yeah.
Thank you.
I had a question. First of all, that was a very, very immensely informative research, and so I really got a lot of knowledge out of that, and I think I'm on the path to doing something similar, but not quite. So as you were presenting, and I also do a lot of work on immigrants, so it kind of resonating with me with the work that I do. So I was also thinking, I mean, culture is great, and taking into consideration educating the people, the patients and the caregivers on Alzheimer. But at the same time, I was thinking about the intersectionality coming from the social point of view, as someone mentioned about the food desert. So sometimes when you intersect race, class, geography, and all of those other different intersectional identities, then you may end up with the population which is absolutely disadvantageous. So how do we teach them? So for example, coming from immigrant culture perspective, I know, and I grew up in India, I know men would never like to admit that they have such mental health problems. Women can be a little bit considerable and seek advice or treatment, but men would never do that, never admit to it. Whether or not they care about the societal stigma, but they themselves, out of their perspective, they would not agree to it. So then how do we address those intersectional identities and educate them based off of those conditional criteria?
Thank you for your question. I think that's very critical. The intersectionality is very, very important to think about. And I think the first thing is that we cannot solve all problems in one go. So for the way we've approached it, at least from our team, is that we try to get as many people in a room as it can be during a dementia education session. So there's some dementia education sessions that we actually have food delivery. A community partner did a dementia education session that was happening at the same time as COVID vaccines was happening. Right after me was another presenter talking about mental health. So it's really, how do we bring things together in a way that can meet the needs of the community, especially a community like the immigrant community that's typically busy. So whenever we're getting them in one space, we're bringing as many and as much resources as we can bring to them to be able to meet some of the needs that they might have when they're coming. So I think that's the way we've approached it, and then doing a lot of education and also making sure that the education is in little chunks to make sure that people are actually taking away, not just offering too much at one time. So that's the way we've approached it. Yeah.
Thank you so much.
All right, Manka, thank you for a great presentation, outstanding job, and congratulations on your final presentation. But you always will be a RCMAR scientist, and you always be a part of our family. So don't stray too far away. Joe, George, do y'all have any closing remarks?
No, I just want to thank Manka again for sharing this exciting work. We look forward to hearing more. It sounds like it's just really taking off. So we'll stay tuned. So thanks again, Manka.
Great job. Can't wait to see what's next.
Great. Everybody have a great weekend. If you're in Baltimore, stay warm.
Thank you all so much. Yeah.